Hi guys, I'm Dr. Tan here. Welcome back to the CME. Today we are going to learn about something that's a bit special, which is about difficult venous access. I will say that generally there's no formal educations about this topic, but in my opinion, this is one of the most important knowledge that all junior doctors must know about. There's a few reasons, but I would just like to highlight the main reason, which is the fact that blood taking, Verona setting are mainly done by our junior doctors like our house officers. Therefore, junior doctors like house officers play an important role in detecting which patients have difficult venous access and to report it to someone more senior like the medical officers so that we can find a solutions for this. I will start off the lecture by giving you a few possible clinical scenarios, mainly to emphasize to you that patients with difficult venous access can be present in any place or in any wards. So they are not only limited to patients from medical ward, they can be patients from ICU, patients who self-present to emergency department, and so on and so forth. After that, I will take you through the potential complications of difficult venous access. Most importantly, we are going to discuss about what central venous line is, which is actually one of the life-saving skills in which all medical officers should know about. And then lastly, we will discuss about how to take blood from central venous line, and this is more relevant for junior doctors or nurses that are actually serving in ICU. Before I take you through the potential complications of difficult venous access, allow me to explain to you briefly what kind of patients are generally susceptible to these problems. I think the first type of patients that we normally see in the clinical practice will be patients that is anasaka. In other words, they have general body swelling. Therefore, they wouldn't have a visible or palpable veins for you to perform your venous punctures or Verona setting. Another group would be cancer patients or patients who have history of intravenous drugs abuse. The reason is because this group of patients generally would have the peripheral veins damaged by the infusions of irritant drugs. So the last group of patients will be patients who are elderly, obese subjects, for the reason that the veins are normally difficult to find. And the last group will be patients that have prolonged hospitalizations and also at the same time have a frequent blood taking for monitorings. The first and the most common complication will be thrombophlebitis. In simple words, it means that the veins is inflamed and also is associated with formation of blood clots along the vein path. So this can happen when the patients have repeated difficult blood taking, and sometimes happen because the Verona has been infected. Therefore, for all doctors, it's compulsory that you must inspect the Verona or the previous venous puncture site daily during your morning round, so that you can take the necessary actions, which include removal of the Veronas. Also, sometimes it will require you to start antibiotics for that patient since there's already a signs of infections. If the thrombophlebitis were missed by the doctors, the patient is going to deteriorate because a simple thrombophlebitis has the potential in developing into a cellulitis. If again no proper actions were taken, it may eventually lead to abscess formations, or in the very rare events, they may develop necrotizing fasciitis as a result. So if any of these complications happen, it will lead to increased morbidities, and sometimes it may even result in fatality. After hearing all this, I hope you will be more vigilant in your morning rounds, and also you'll be able to detect thrombophlebitis or phlebitis at the earliest stage and be able to take the necessary actions. And another point to drive home is that any Verona that's not needed should be removed. Most hospitals would have their own clinical pathway for difficult venous access. So for our hospitals, we actually have this protocol in which if the junior doctors have failed to take the blood or to set the Verona within 2 attempts, then they should alert the more senior personnel like the medical officers. So at the time, we should do an ultrasound assessment to look for suitable peripheral vascular access. If it was deemed that there is no suitable peripheral vascular access from this sonographic assessment, then we have to consider whether or not this patient would need an urgent central venous line. Well, as this title says, most of the bad things happen at night. Therefore, it will be your nightmare. Let's say you have a patient that already have a difficult vascular access, but somehow we did not prepare for the worst. So think about it. Such patients, the only variola over the hands dislodged and he collapsed because the inotropic support the infusion was interrupted. Or sometimes maybe to a lesser extent, not that serious, variola dislodged during your on-call and the patient missed medications as a result. I hope the previous slide would make you able to appreciate that why is it important for you to be able to perform central venous line when you become medical officers, because these life-saving procedures will be totally rely on you, especially when you're working in a district hospital. So let's go through the basic indications of a central venous line. So the first indications would be that it will be used as an emergency venous access, like what I have mentioned to you in the previous slide. And also it can be used for resuscitations in subjects who are intravenously depleted. So not uncommonly, patients who have prolonged hospitalizations and require multiple blood taking, this CVL can be inserted for that purpose as well. So a common scenario would be patients who have a prolonged ICU stay. Another indications would be for our cancer patients that require frequent infusions of irritant drugs that may damage the smaller veins. But however, nowadays we tend to insert chemoport instead rather than a central venous line. So another indications for this CVL would be for your renal replacement therapy, which is your hemodialysis. And also sometimes this procedure should be done for patients that require transvenous pacings. And lastly, it can be used as an access for parenteral feeding as well. I would also like to take this opportunity to clarify to all the viewers that nowadays we are no longer inserting central venous line for the purpose of monitoring patients' fluid status, because there's actually another method which is not only non-invasive, at the same time it can provide more accurate information, which is our point of care ultrasounds. So through the simple measurements of this inferior vena cava, it will give us an accurate idea of what is the patient fluid status. Technically, I would say there isn't much absolute contraindications to insertions of CVL, looking at the many life-saving benefits that it can offer. But however, if the patient refuses to do so, then of course we have to respect our patient's autonomy. Another point to consider is that if there is infections over the underlying skin, then of course do not perform it at the site. But you always have the options of performing at the other side. For example, if there is an infection over the neck, then you may consider using the femoral approach. And the last point to highlight to you is that if the subjects have uncorrected coagulopathy or thrombocytopenia, you should try not to insert a CVL unless it is absolutely indicated. In that case, of course, it should be done by more skilled personnel under the ultrasound guidance, as well as with the blood products coverage peri-procedure. Generally speaking, there are three anatomical sites to insert your central venous line. So the first one will be your internal jugular vein, the second will be through your subclavian vein, lastly it can be placed through your femoral veins. But in practice, the most commonly practiced CVL insertion would be still via your internal jugular veins and femoral vein. Rarely we will perform catheterizations through the subclavian vein because it carries the highest risk of pneumothorax. Before I proceed, I must emphasize that all the procedures must be able to compare the advantages and disadvantages of different central venous access. After the considerations, only then you should choose the best site for your CVL. So let's take a look at the advantages of IJC. So generally speaking, your internal jugular veins will be the most readily visible veins under the ultrasound scan, and also it will be easily accessed because most of the time it lies relatively closer to the surface as opposed to your femoral vein, where generally there will be a thicker overlying skin before you can access the vein. But however, it does carry some risk as well. So the commonest risk that we'll quote is that sometimes it may cause pneumothorax, or in the more severe form, it can even cause hemothorax. Another important message to drive home is that generally if the patients have coagulopathy or thrombocytopenia, which increase the risk of bleeding, the procedurists will try their best to avoid inserting a catheter through the internal jugular veins, for the reason that if there's any arterial puncture during the procedure, the patients may develop a neck hematoma. If the hematoma is not within control, it will expand and eventually cause life-threatening airway compressions. Also, the patient may also be at risk of cardiac arrhythmia during the procedure because if the guide wire were to be inserted too deeply, it may irritate the ventricles, triggering ventricular arrhythmias. And last consideration will be the risk of infections, just like any other procedures. But generally speaking, the risk of infections, or we'll call it like risk of CRBSI, are generally the lowest as compared to other access like your femoral access, which was actually inserted near the groin. So next, let's take a look at femoral vein catheters. Again, it has its own advantages as also its own sets of risks and complications as compared to your IJC. So generally, your femoral vein catheterizations are relatively safer because there is actually less important structure around it. For example, if your IJC you're actually performing close to the airway. Another point is that femoral arterial punctures generally can be treated with compressions. However, in subjects who are obese, normally internal jugular vein catheterization will be favored because it will be technically very difficult to insert a femoral vein catheter in obese subjects. Another risk or complications that we would consider is that femoral vein catheterization actually has a higher risk of infections because it is near to the groin. Another risk would be your femoral nerve injury or the risk of retroperitoneal hemorrhage, but these two complications rarely happen. Central venous lines that are inserted require specialized care. So medically, we will call this as a central line care bundle. And this bundle will talk about proper hand hygiene, daily review of the central venous line and to promptly remove it when it is no longer needed, and also how to take blood correctly through the central venous lines. So ultimately, we would like to preserve the central venous line, and also most importantly is to prevent CRBSI or premature failure of the CVL. So this slide will provide you a step-by-step guide on how to take blood from a patient's central venous line. Of course, the first step would be informing and explaining the procedure to the patients. After that, you need to prepare a clean workplace and to gather all your equipment beforehand. Also, please observe strict hand hygiene during these procedures. Make sure that you have washed your hands and also don a pair of gloves before doing so. If the patient to have any infusion solutions that is connected to this triple lumen, please switch it off temporarily. And then the next step would be scrubbing the hub with an alcohol wipe for around 10 to 15 seconds and let it dry. So after the hub has dried up already, then please use your first syringe to aspirate the saline that is filling the tubing and discard it. After that, only then you withdraw the blood sample using another syringe. Once the blood samples have been taken, then you must make sure that you would flush the tubing with your sterile saline. After that, you recap it. Then you will have to scrub the hub again with alcohol wipe for another 10 to 15 seconds. So lastly, and also the most important step, is that if you have turned off any infusions before that, right, please make sure that you will turn back on the infusions solutions at the end. There are actually reasons why we are so strict with the technique that you use when you're taking blood from a CVL, because if not being done properly, right, it will actually cause complications or morbidities. For example, if you do not take the blood using the hygienic technique that I have explained to you earlier, you can actually infect the catheters, like causing infections or CRBSI. If this happens, sometimes not only we have to give the patients additional antibiotics or to extend the antibiotics duration sometimes, but we have no choice but have to remove the CVL and to reinsert a new one if there's a need. And also, if you did not aspirate or discard the saline from the tubing in advance, right, your blood samples will be diluted. Lastly, if you did not flush the tubing properly, it will cause the tubing to be blocked or occluded. Thank you for watching until the end. I hope this video has given you a new perspective about this topic, and please subscribe to the channels and share it with your friends that might benefit from this. Thank you.